Hello and welcome to Primary Care Today. I'm your host, Dr. Brian McDonough on ReachMD, and we are beginning a very exciting new show, one I've been waiting to do for quite some time, essentially because we get to talk about primary care. We talk about medicine and how primary care providers provide medicine. Now, it isn't just limited to a primary care audience. Any physician can listen because, let's face it, we talk about a wide variety of issues. As we do this show week after week, we're going to talk about a lot of different things. Hopefully, you'll get to know me a little better. I'll get to know many of you through your thoughts and what you would like as topics. And that's one of the things. I want you to reach out to ReachMD and let us know what topics you would like to have on this program. But rather than talk a lot about the program right now, I'd like to get right into the topic at hand. And today we're talking sports medicine and orthopedics with Dr. John Kelly. Dr. Kelly is an orthopedic surgeon at the University of Pennsylvania. And Dr. Kelly and I have known each other for quite some time, and I know of his work as a clinician. I also know of his work, and we'll talk a little later, about his work helping physicians deal with stress. And since this is a physician audience, I know we have a great deal of stress we all share, and we'll talk a little about that later. But Dr. Kelly, first of all, welcome to the program.
Thanks, Brian. It's great to be here.
My first question for you, for a primary care audience, sports medicine is certainly, everybody thinks they know a little bit about it, but there's just so many aspects to it. When you see someone and you're talking to a family physician or you're talking to an internist who's doing sports medicine, what do you tell them to focus on as far as the average person who comes in and what they should be thinking about?
I think that one of the blessings of being an orthopedist is that it trains you to think of simple and important things and not missing the forest for the trees, so to speak. So usually patients come in with really one basic problem, and if you focus on that and obviously not ignore the others, I think you'll take better care of your patients and meet their expectations.
I know you have many areas of interest, but one of your particular areas of interest is the shoulder and issues associated with the shoulder and repairing it surgically. But we get a lot of patients who come in who say, my shoulder's really bothering me, and it's starting off with an evaluation like that. Are there certain questions we should be asking and looking at to help us out in making the best diagnosis?
Oh, sure. The great William Osler, I use this quote because we teach residents, said, listen to the patient and he or she will tell you the disease. So, we surgeons are pretty type A squared and we like to rush in and rush out. Just sit down. Just ask them, how can I help you? And just tell me the problem. And that will tell you the problem. If it's the shoulder, for instance, if they have night pain, if they have pain lying on the shoulder, if they point to their deltoid tuberosity, it's almost always a cuff issue. If they have pain overhead or pain in front of them, they were thinking more of an overhead an instability issue. Pain behind the scapular plane, usually anterior pain. When the arm is in front of the scapular plane, usually a posterior issue. And then we have throwers, anterior pains, usually less worrisome than posterior pain. And pain and follow-through may be more labral-related, posterior labral versus anterior labral. So it really behooves the doc just to sit down and listen. And then we'll get to what I call the man scan, the woman scan. We have so many tests to our avail. But I think that, Dr. McDonough, we've lost the art of hands-on medicine. I had the blessing of spending 1 month in Ireland when I was a medical student and didn't have much money back then. When I was in med school, it was actually, the 19th century, but besides the point, there was very little resources to people in Ireland at that time, the doctors, so they really had to very, very much heavily rely on the physical examination. And I took away with that the very important notion that, we order too many tests in America. I really do think that not everybody needs the ultra-generation MRI, not every patient needs an MRI. So I think that we've lost the art of listening to patients and to doing a real good comprehensive physical examination. And that's where I start in every patient.
So really you ask those questions. I agree with you. I think one of the things I've found in my years seeing patients is if you listen long enough, they pretty much tell you what they have, and you almost would have to be a fool to miss it because they'll come right out and say the key words and what's going on, and they do help you with that diagnosis.
And furthermore, you can ask the patient, so what do you think? You have someone with, for instance, groin pain. You say, well, do you think it's your hip? Do you think it's your back? Do you think you have a hernia? And what do you think? And oftentimes they give you very, very important insights. They're just sometimes too bashful to say, well, doc, I've heard that hernias cause pain when I sneeze, and you know what? It does light me up. I think I have a hernia. Like, okay, all right. Well, let's look at your leg. So I think it's so important to have that level of trust and comfort with the patient, and sit down and ask open-ended questions, and And they'll tell you their story. They really will. They really will. So I've said a lot, but I think the most important thing is focus on what the particular principal illness is, and don't lose sight of other things of that when you look at other things going on. But most people come to see us sports docs for one singular problem. Usually, there's other associated problems, but one singular issue. And I'm really delighted to be on the show because, we go to these conferences, and I call the non-operative sports doctors the real doctors, because I'm very comfortable with the surgical aspects and the musculoskeletal anatomy and so forth, but the medical aspects of medicine, asthma, heart disease, heat illness, some of the hormonal things. Boy, thank God we have real doctors to our avail. And I've worked with two very, very good family practice, sports medicine trained physicians.
And when you look at that family medicine in sports medicine, what is it different that they bring to the table from your perspective?
Well, it's a whole different way of looking at things, a whole, paradigm shift. I think that their bias is, just to look at the patient a little differently, and they have a natural inclination, which is a good one, not to operate, exhaust every possible means of avoiding surgery. I think one of the misgivings of our healthcare system is that there's a little bit of a distance. There's no distance enough not to operate. I think that's going to change with some of the bundled payments heading our way and so forth. You want a certain quantum of resources. Say, what's the best way to take care of this patient with these resources? And very often it's without surgery. I did a little tabulation a while back about my practice profile. About 92% of the patients I see, I don't do surgery on. So what I do chiefly is non-operative. Prevention is very, very important, particularly in the realm of the shoulder and thrower shoulder, and we can talk about those things a little bit later.
I think when you talk about, like you were talking about something key, which is the idea of prevention and trying to disagree maybe with your body, your body's saying, let's go out and play, let's go out and do this, let's not stretch, but really to get the prevention as the patient, but also teaching the prevention. You were going to talk a little about the shoulder and trying to avoid problems with it. What are some of those things?
Well, I think they have a great passion for avoidance of injury, and let's talk about two populations. One is the thrower, and the second is the person with the cuff disease. So the thrower, we find that most throwers develop pathologic adaptations to throwing, a lot of fastballs, curveballs. Their posterior capsule gets tight, their scapula starts kicking out. They develop what we call kinetic chain abnormalities. If you take a young man, young woman in their mid to late teens, and you do what I would call a comprehensive kinetic chain evaluation, look at their lead leg hip interrotation and lead leg quad tightness, lead leg hip abductor strength, their scapula, their posterior capsule tightness, and their cuff strength in abduction. If you look at all those things and make an assessment and try to correct those early on, you're going to save a lot of labral tears, because we find that the slap tear, the labral tear, is really the culmination of maladaptive throwing habits over several months, if not years. We also love the whole concept of the kinetic chain, where if things break down downstream, they're going to have increased stress further down the line. For instance, elbow pain in a young thrower is very commonly ascribed to shoulder problems. So if a posterior capsule in the shoulder is tight, that kid will rely more on his elbow for what we call long axis rotation. So I can't tell you, Dr. McDonough, how many patients I have helped their elbow by just simply rehabbing their shoulder. I can't tell you how many throwers I've also helped by just addressing their trunk, or their lower extremity, their core. 55% of the throwing power is generated from the lower extremity. So if someone has an unrehabbed ankle sprain, that, believe it or not, could translate to increased demands on the shoulder and to shoulder issues. So we have to look at the whole person. And I have the gift of being a little holistic in nature, California-like. I give patients vitamins too and things of that nature, and I look at stress as a means of maybe interfering with the rehab. Now, the cuff patient is also prevention, is the name of the game in those patients as well, because we sometimes see partial thickness cuff tears advance to full thickness cuff tears, small tears get bigger. Tendinitis can also advance to a full thickness tear. So my patients that are over 40, over 50, we have them do a good scapular retraction program, a good cuff strengthening program. And you and I are old weekend warriors and playing sports. I discourage heavy lifting in someone over 45, 50. I think their shoulders aren't able to handle that. I've seen many, many men and women with lift overhead for years and years, the glenohumeral arthrosis and rotator cuff tears. So you just got to ramp it down a little bit and just start exercising smartly as we age, and give up the big guns for just the lean and mean look.
I'm Dr. Brian McDonough. You're listening to Primary Care today on ReachMD. My guest is Dr. John Kelly from the University of Pennsylvania. Believe it or not, we have less than 5 minutes, and I do want to talk with you, Dr. Kelly, about a particular interest of yours. We've talked about it on many occasions, but you are really someone who's active, who lectures around the country, talking about stress and stress reduction, humor in medicine, kind of a different, as you say, a holistic approach for the healthcare provider, for the physician. Tell me a little bit about your philosophy and share with some of our listeners of what you find so interesting and helpful about it.
Well, we most of us in medicine have a delayed onset adolescence. We spent all those years studying, and we, I think, had a lot of developmental delay, if you will. So the triad I talk about in my lectures, and this is harder in wisdom, Dr. McDonough, because I've been to the drain, shall we say. I've had several years of just overwork, burnout, stress, anxiety. And I realize that relationships are important, so I make a very, very important effort to focus on my marriage of 25 years. That's number one. Doctors have to recognize that, they're about as happy as their marriage is. As the marriage goes, so goeth their happiness. So it has to be an investment. Number two, self-care. Physician, heal thyself. We neglect our own health. I place a premium on sleep and exercise. I eat well. I try to take my vitamins. And I think it's important to develop at least one good stress management technique. I took a course in mindfulness about 3 years ago. It was a real game changer for me. And, I focus on that in my lectures about living in the moment. When you're in the moment, anxiety, depression kind of just vanquish because, when you're focused totally in the present moment, all the other stuff kind of goes away and sort of inner wisdom takes over, and you live a much more inspired and passionate life versus a worried and compulsive life. And the third thing I think I like to focus is just living a life of integrity and honor. It's very hard not to be happy when you're a good person. No agendas, putting the patient's interests first, loving your family, telling the truth, saying what you do and doing what you say, not having a pseudo-self, living within your own limits. One of the most stressful things I've encountered in my life is doing cases that I shouldn't be doing. Trying to keep your ego in check and just living a more inspired, humble, and honorable life. Those are the ingredients to happy doctors, personhood. We so many times go on the treadmill and realize, wake up in our 50s and 60s and say, oh my gosh, I don't know my kids. My wife, my marriage is like just plus minus. I'm not a happy camper. Just so we listen to our body and pain, listen to your emotion and say, if I'm not happy, why not? How am I looking at life the wrong way, and what can I do to change it?
They're all good points, and with only about a minute and a half to go, I wanted to ask you, one of the things is we're in a really rough time in medicine in the sense that there's a lot more economic pressure in most healthcare environments. Things are changing dramatically. A lot of people who are physicians are wondering what's 1 month, 2 months, a year down the road. How do you deal with that? Like you say, dealing in the moment, living in the moment, but how do you offset those concerns?
Well, I do that by living in the moment. I realize that the best I can do is what I can do right now, and by taking care of each patient one at a time the best I can. We're talking about quality care, value-driven care. Nothing gives a patient a more sense of satisfaction than, when you care. There's an old expression we use in our communication skills workshop, which I teach for our Academy of Orthopedic Surgeons, is patients don't care how much you know until they know how much you care. So I don't give much credence to Press-Ganey, all those stuff. I was raised by the Franciscan nuns. I just figure you take care of patients like they're your family, and everything works out for the best. And you won't be so stressed out about, how am I doing these evaluations? So with the old school approach, still goes a long way, where you just spend a little more time at the expense of maybe seeing a few less patients a day. But that's where the quality comes in, and the doctor's lives will be much more enriched because you feel much more satisfied in giving that person the care he or she deserves.
Dr. Kelly, I want to thank you for joining us on Primary Care today. Couldn't have thought of a better guest to have on the first program, and thanks again for taking the time.
Brian, it's my pleasure. You're a good guy, and I'm happy to help.
Thank you. We'll talk to you next time on Primary Care Today.